Hello, everyone. Good evening or good afternoon, depending where you are. This is a presentation of the GHAPP MASLD Community Network, sponsored by Madrigal. Today, we're going to be discussing MASLD and MetALD. My name is Scott Springer. I'm a PA practicing outpatient hepatology at Erie County Medical Center in Buffalo, New York. You can use this QR code to kind of mark that you are attending this meeting if you want credit for attending. So let's jump into the case. So Ashley is our patient. She is a 52-year-old woman referred for evaluation of an abdominal sonogram showing mild hepatomegaly and increased hepatic echogenicity consistent with steatosis. She feels well without complaints. So like we said, she's 52. She is Caucasian, female. Her BMI is 29.4 kilograms per meter squared. What else do we have on Ashley? So her medical history includes PCOS, hypertension, hyperlipidemia. She averages 2 glasses of wine per day. On physical exam, her liver edge is smooth and non-tender. Medications include amlodipine, atorvastatin, and milk thistle. So we know we have hepatic steatosis by ultrasound. We have some information about medications, other diagnoses, metabolic risk factors for hepatic steatosis. And we also know that she has approximately 2 drinks per day. So that's kind of our starting point. We get some objective findings on the patient: blood pressure 140/78. That says respiratory rate 76. I'm assuming that's heart rate, because that would be quite tachypnic. Temperature is 98.4. Like we said earlier, BMI is a little bit elevated at 29.4 kilograms per meter squared. We look over at laboratory studies. Aminotransferases are both mildly elevated. Alkaline phosphatase is kind of at the upper limit of normal. Total bili, the same. She is not thrombocytopenic, which is reassuring for ruling out advanced fibrosis with portal hypertension. Hemoglobin A1C is nice at 5.9%, and her triglycerides are 185. Due to the hepatic steatosis, we order some non-invasive testing. For this patient, we were able to order a FibroScan, which is going to help us assess the liver stiffness as well as stage the amount of fat, the amount of steatosis in the liver. So the FibroScan suggests a liver stiffness measurement of 11.4 kilopascals. And if you look over to the right, that is consistent with significant fibrosis, F3 out of F4. So we certainly have advanced fibrosis by FibroScan. And the CAP score, which we use to stage the steatosis, is in the severe range, greater than 268. The reading that the FibroScan gave us was 310. So we know we have severe steatosis with advanced fibrosis. We know there are some cardiometabolic risk factors. She's on medication therapy for that. And also there's some alcohol use. So looking at the relatively recent nomenclature changes to steatotic liver disease, we kind of have this metabolic dysfunction to alcohol-associated steatosis spectrum. So both metabolic dysfunction and moderate to heavy regular alcohol use will produce hepatic steatosis, right? But we know that these things don't exist in a vacuum, and many of our patients, have both cardiometabolic risk factors and alcohol use. So to bridge the gap between these two diagnoses, we have the diagnosis of MetALD. Okay, the spectrum kind of ranges from like a metabolic predominant to an alcohol predominant MetALD, and that's just based off of the quantity of alcohol use. You see on this chart here, there's cutoffs for weekly alcohol intake and daily alcohol intake. The important thing to know is that one standard drink is about 14 grams of alcohol. So that's where these numbers are coming from. So where you see where it says MASLD predominant, The 140/210, that's for males and females respectively. And then on the ALD side, the 350 and 420, that is also for females and males respectively. So that's the weekly amounts. And then underneath it, you have the daily amounts. So for our patient, she was drinking about 2 drinks per day. If um, one drink is 14 grams of alcohol, that's about 28 grams of alcohol. So that would put her right between the 20 and 30, which is more on the MASLD predominant side. Now, keep in mind, while we know that, at least based on the patient's report of their alcohol use and the history of metabolic dysfunction, there may be other etiologies of hepatic steatosis, much less common, but nonetheless, we should look for these things. Specific etiology, steatotic liver disease. It's possible any of her medications are causing liver injury. Are there any monogenic diseases like Wilson's disease? We have to rule these types of things out. Viral hepatitis, because certainly if those are present, they also could be contributing and they need to be addressed. These are kind of a visual representation with volumes of what a standard 14 grams of ethanol drink is. So it's important to have an understanding of this because patients really don't. They have no reason to really think of their alcohol consumption in terms of grams. So it's our job to kind of translate it for them. I think the best way to ask about this is, tell me a bit about your alcohol use. How much do you go through? What do you buy and how quickly do you go through it? That kind of can help you do the math and kind of figure it out. Because patients are notoriously hard to nail down in their alcohol use. And I think that's just part of human nature. I don't think that they're trying to be elusive. It's just, a lot of the time it's not something that they're really keeping great track of necessarily. So we have to help them do it. These are some conversions to help us calculate the grams of alcohol per day and per week. So this is a image that's kind of showing the pathways of, both for metabolic dysfunction, steatosis, and alcohol-associated steatosis, how there's common pathways, and then there's also like synergistic effects. So I will read directly from the paper that this came from because I'm not as good as what they wrote here, able to rattle that off. So essentially, when metabolic dysfunction and alcohol consumption coexist, the pathogenic pathways that lead to liver damage are likely to be both additive and synergistic. So essentially, on their own, they cause impaired lipid handling, oxidative and endoplasmic reticular stress, and cell death. But when combined, the mechanisms kind of have a synergistic effect and enhance that and accelerate it. Okay. In the setting of dual metabolic and alcohol-related fatty liver, extracellular vesicles released by injured cells and apoptic bodies crosstalk with immune cells, such as resident macrophages and incoming mononuclear cells, leading to the formation of a pro-inflammatory loop, which you see in this kind of orange salmon-colored box to the right. Notably, upregulation of the chemokine CXCL1, which is involved in recruiting and activating neutrophils, has been suggested to enhance neutrophil-driven steatohepatitis in combined metabolic and alcohol-related fatty liver. Finally, clinical and experimental studies suggest that enhanced fibrogenesis is also likely to occur in this setting, thereby contributing to disease progression. So essentially, on their own, we certainly know that each of these distinct processes can lead to steatohepatitis and fibrosis. Together, there's a number of mechanisms that accelerate that and have synergistic effects on the development of fibrosis and disease progression. This is an interesting representation of risk for decompensation across the spectrum of steatotic, metabolic steatotic liver disease and alcohol-associated steatotic liver disease. So essentially what we're looking at is for patients who would be diagnosed with MASLD versus MetALD based off their alcohol use versus ALD based off their alcohol use, what are the differences in 5-year decompensation risk? So we see first looking at patients without advanced fibrosis, somewhere between F0 to 1 fibrosis, the 5-year risk As you increase the alcohol use, it goes from less than 1% in MASLD to 1 to 5% in MetALD to 2 to 15% in ALD. Then if we jump up to patients with advanced fibrosis and the same amounts of alcohol use, we see that essentially it doubles on itself. So for patients with advanced fibrosis with MASLD, they have a 5-year risk of decompensation of about 5 to 15%. But essentially, as you increase the alcohol use to be classified within the thresholds for MetALD versus ALD, you're doubling that risk each time, essentially. So, certainly we know that patients with a pure MASH cirrhosis, have risk for decompensation. That's going to happen. But as you add alcohol to the mix, especially when you kind of cross the threshold of amount of alcohol use consistent with alcohol-associated liver disease, the risk drastically increases. So what we're getting at here is clinically, how do we differentiate this? So this is kind of a visual representation of a study that was published in the Journal of Hepatology in 2022. It investigated alcohol consumption in patients with presumed NAFLD and ALD, the old nomenclature. This is 2022, using novel objective alcohol markers. It was a prospective observational study with an N of 184. Essentially, what they did was they identified patients with NAFLD, and at the time, the proposed new nomenclature was MAFLD. So patients who met those respective criteria, they assessed their alcohol intake by doing testing of the ethyl glucuronide in both their hair and urine. Additionally, they collected information on audit C. So they did the audit C on patients. They got a metric called carbohydrate deficient transferrin. They looked at a CBC for mean corpuscular volume. They looked at GGT and an ALD NAFLD index. Essentially, what they found was that the optimal diagnostic means of the ones that they utilized, hair, the area under curve, meaning essentially the sensitivity of this testing for considerable alcohol use, patients that are at risk of alcohol-related liver damage, was the hair ETG testing. So essentially, overall, in total, somewhere between 25 and 28.6% of the patients that were characterized as NAFLD or MAFLD had levels of alcohol consumption based off of this testing that put them at risk for alcohol-related liver damage. The takeaway of this is that we should be using objective biomarkers to assess alcohol use in patients, because if we are misidentifying patients with MetALD as just having MASLD, we're missing an opportunity to intervene and slow down the disease progression by intervening with their alcohol use. So this is kind of what we were getting at here. This is, we're looking at the metabolic versus alcohol-associated steatotic liver disease. We find steatosis in a patient like this on ultrasonography. We have to rule out the less likely causes, doing some workup, but our important things are establishing is there metabolic dysfunction, and assessing the alcohol use. So the metabolic risk factors, metabolic criteria are listed here. We know BMI over 25, with adjustments for race or ethnicity, fasting serum glucose, blood pressure greater than 130 over 85, or on an antihypertensive, triglycerides, HDL levels. So one important thing that's added on here that can help us distinguish between patients with quantities of alcohol use consistent with MetALD is if there's patients that have only hypertension or only hypertriglyceridemia as their metabolic dysfunction, you want to increase your suspicion that there may be alcohol use at play. So because of that, the last study we discussed talked about ETG testing. PEth testing is another great modality we can use. It's especially helpful because it does not vary based on liver function. It's not dependent on liver function. So we can use this test with accuracy across all of our spectrum of patients with chronic liver disease. Okay. So when you have isolated cardiometabolic risk factors, especially hypertension or hypertriglyceridemia, you should be doing a PEth. Additionally, if patients report alcohol use, it's recommended to use a PEth to get a better quantification of that, because this spectrum of MASLD to MetALD to ALD, it gives us the ability to kind of adjust our diagnosis and reevaluate over time for patients that reduce their alcohol use. And PEth can be an important tool in correlating that, and in patients who deny alcohol use, confirming that. So we know really what the etiology is. So on our patient, we did a PEth test. It came back as 120 nanograms per liter, which is consistent with moderate to heavy alcohol consumption, which is somewhat consistent with kind of the grams of alcohol that she reported to us. There aren't any direct, values for PEth to characterize Met ALD versus ALD versus MASLD. But we do confirm that there is at least a moderate amount of alcohol use going on to strengthen our diagnosis of Met ALD and not just MASLD. It is possible that this also could be characterized as ALD, but either way, we know that alcohol use is at play and it's something we need to tackle. So PEth testing, essentially, these are a few different kind of ways of displaying the utility of it. So after one single binge use, PEth, which is like a metabolite of alcohol, our body's alcohol metabolism, it shows that over up to 12 days after a single episode of alcohol use, that the PEth was detectable. So, the further out you are from use, the lower the number is going to be, but at least it can kind of give you a flag that yes, there was alcohol use, even if it wasn't recent, and kind of increase your radar for it. Another piece of the puzzle is that there's very little variability by sex and BMI. We talked about, how liver function doesn't impact this in our assessment of it. Additionally, data shows that there is minimal variability by sex or BMI. So it's a pretty easy to utilize and transfer tool across our patients. This is kind of the opposite of the other study we talked about where they used the ETG testing and Audit C to identify alcohol use in patients. This is a San Diego-based liver study where they identified patients with who are overweight or obese with reported alcohol use, and they took those risk factors, so one cardiometabolic risk factor, and alcohol use, reported alcohol use, and screened the patients down. Of the 659 that they screened, 617 were enrolled, and 333 of them essentially qualified by having elevated BMI and alcohol consumption that was consistent with MetALD or ALD. Okay. Of the 333 subjects, 97 of them were found to be at risk for were found to have at risk MetALD when they did imaging looking at liver stiffness and steatosis. So again, we know that these, distinct but synergistic, criteria and risk factors do lead to fibrosis in patients that are drinking and have extra body mass. And this is just one cardiometabolic metric. So, across all the cardiometabolic criteria for MASLD, I'm sure we would find similar findings. So looking back at the medical history here, we do know that two of the cardiometabolic criteria, hypertension and hyperlipidemia, which she's on medical therapy for both of those. We have two cardiometabolic risk factors, but those are the two that are most associated with, a heavier disease burden of the alcohol use, like we discussed earlier. Also, there's PCOS listed there, not a cardiometabolic risk factor, but certainly is associated with metabolic dysfunction associated steatohepatitis and steatotic liver disease. So what's the relationship between alcohol and hypertension? This is a meta-analysis that looked at 32 randomized controlled trials with a total number of 767 participants evaluating the effects of alcohol use on blood pressure. Essentially, what you find is that alcohol has a biphasic effect on blood pressure, meaning immediately after use for 12 hours, blood pressure drops, but beyond that 12-hour mark, blood pressure is increased. So we know in patients that are regularly drinking, if we were to assess their blood pressure near to when they were drinking, it would kind of be lower than maybe baseline. But again, if they've been abstinent for 13 plus hours, that blood pressure is probably going to be elevated, and that's why our suspicion should be raised. Similarly, alcohol and hypertriglyceridemia. This is a study that showed patients that compared patients with baseline hypertriglyceridemia to patients without hypertriglyceridemia, and what kind of acute triglyceride levels were over the 10 hours after administration of 2 standard drinks or water. Essentially, what it finds is that in the short term, over 10 hours, in both patients with and without hypertriglyceridemia at baseline, alcohol compared to water increases plasma triglycerides. So again, if a patient is drinking in somewhat close proximity to coming to see you and you're evaluating their lipids, that is another thing that can increase the serum levels of triglycerides. So we saw all of these things here. What is our diagnosis? So because of the quantity of alcohol use, because of the cardiometabolic risk factors, of which she has 3 with the obesity, hypertension, and hyperlipidemia, we would characterize her as a MASLD predominant MetALD. The alcohol use crosses that threshold where she passes from MASLD to MetALD, but it doesn't necessarily meet the extent where she would be ALD. So MASLD predominant MetALD is our diagnosis. What are the current treatments? So we know that Mediterranean diet specifically, has good evidence supporting its use in steatotic liver disease, exercise, and weight loss. Essentially, we know if a patient is able to reduce body mass by possibly 7 to 10% and maintain that weight loss, there's a really good chance that their steatosis and fibrosis will regress. Is she a candidate for resmetirom? So resmetirom is specifically indicated for MASH. So I would say yes, she could be, especially if we're able to help reduce her alcohol use. So our recommendation would be stop using alcohol. In any patient with chronic liver disease, the benefits of completely omitting alcohol use, complete abstinence, are very strong, especially in patients with cardiometabolic risk factors, even without known liver disease. Certainly, we should counsel this patient on alcohol abstinence and provide them with resources, MAUD if they need it, to help them achieve that if they're interested in it. So I would say candidate for resmetirom, potentially if we are able to reduce alcohol use, I think it would be a slam dunk patient for resmetirom. Also important to note, current treatments, I think before this PowerPoint was made, semaglutide was approved for use in MASH. So, whether or not this patient will meet criteria for that, I don't know. No real evidence of type 2 diabetes or prediabetes in this patient. But depending on her coverage, maybe that's another thing to consider. And anecdotally, there's some evidence that the GLP-1 receptor agonists can help reduce alcohol use too. So, that's not on label, that's not proven, but, maybe some dual benefit in a patient like this. So, we want to evaluate all the options we have, possibly combination therapy if it's appropriate. Lastly here, it says, does she need HCC screening? It says yes. I would say maybe. So the recommendations and the guidelines vary on this. For example, if she's established as a F3 patient with MASH, AASLD guidelines would actually say no, don't screen her because she's pre-cirrhotic, though EASL guidelines would say, you know, it's not a yes or a no. It's based off of the patient and risk factors. You can make that determination. That being said, I generally err on the side of caution. And if patients are really close to that F4 threshold on transient elastography or on a biopsy, if they get a biopsy, or if their ELF test is really high, I certainly would discuss HCC screening with a serum AFP level and a liver ultrasound. And if they were amenable to it, I think it's worth investigating and ordering every 6 months or so. So, because we know that often we aren't great at identifying alcohol use in our patients for a number of reasons, because of their disclosure of it, because of how we ask about it, because we don't ask about it at all. We don't do a good job of that. It is ideal that in clinical trials, we use objective biomarkers for assessing alcohol use when we're studying steatotic liver disease. Again, like I said, to overcome the underreported alcohol use, to standardize the assessment of recent alcohol use by using these objective biomarkers, and to confirm alcohol abstinence. And when we're doing studies with MASLD without concomitant alcohol use. Additionally, in clinical trials, we need to ensure that all drivers of liver disease are present. So consider more than one cardiometabolic risk factor in studies on steatotic liver disease, because we know that with increasing number of MASLD cardiometabolic risk factors, there is an increased risk for progression. And also you want to ensure the persistence of hypertension or hyperlipidemia after stopping alcohol use, because we know that use of alcohol is associated with both transient and longer term elevation of both of those metrics. So, if at baseline we think those are metabolic dysfunction and then alcohol use stops and they go away, it really was ALD all along. So it's important to kind of make that distinction. And then you want to consider exposure to risk factors. So you want to make sure that patients are fulfilling the criteria during the last 6 to 12 months. Are these ongoing risk factors? Are they previous risk factors? So attention needs to be made to, when these cardiometabolic risk factors were identified, when the quantification of alcohol use was made. So that is an important piece of the puzzle, because of kind of the dynamic nature where patients can move between MASLD, MetALD, ALD based off of their alcohol use and cardiometabolic risk factors. Our take-home messages. New definition of MetALD is alcohol intake beyond 140 to 350 grams and 210 to 420 grams per week for women and men respectively. So once they cross that threshold, they jump from MASLD to MetALD. Clinical criteria can underestimate MetALD and also ALD. So utilization of alcohol biomarkers like PEth, both clinically and in research, is valuable. You want to ensure that the drivers of liver disease are present. So you need to reassess the metabolic dysfunction over time, especially if patients are reducing alcohol use, because things like hypertension and hypertriglyceridemia may improve or resolve with alcohol abstinence and kind of change how we classify the disease. And you want to consider adequate exposure to risk factors. Criteria for clinical research should facilitate an objective MetALD diagnosis, allowing comparisons among different sociocultural realities. So again, there's a lot of variables in this diagnosis. Male versus female is very binary in nature, but there's a lot of variables and a lot of variability in the individuals we work with. So finding a more objective metric, maybe by using alcohol biomarkers, by factoring in other sociocultural components of our patients, may be the best way to clinically research MetALD. If you are interested in further disease state education on steatotic liver disease, specifically metabolic dysfunction associated steatotic liver disease, please visit the GHAPP MASLD Community Network for additional disease state education and a Res Differ webcast. You can use this QR code. And lastly, if you would like to give some feedback, you can use this QR code right here. And that concludes our presentation. Any questions or concerns, I'm happy to answer. But if not, thanks for joining us.